São duas perguntas que vieram já pelo aplicativo. A primeira, eu acho que o teu último slide já respondeu bastante, mas a questão é, na sua experiência, quais os antimicrobianos melhor associação para atuação em biofilmes por gram-negativos? Multiresistentes, claro.
Okay, thank you for the question. So I have just presented combination with fosfomycin and with colistin. I have no clinical experience with fosfomycin for gram-negatives. I have some for gram-positives with good results. But in the particular case of gram-negatives, whenever I can use ciprofloxacin, which would be the case of a multi-drug-resistant gram-negative bacilli, I use colistin plus beta-lactams. I tried the beta-lactam to be administered as continuous infusion, so its PK/PD profile is better, and then I administer colistin, and I just monitor the patient very closely in order to see if he is going to develop resistance.
Qual o papel da rifampicina para o tratamento de cepas produtoras de KPC?
That's a very good question, and I don't have a proper answer for this. We know that there are some gram-negatives such as Pseudomonas aeruginosa and Acinetobacter baumannii that can respond to rifampin in combination with another antibiotic such as colistin, so the combination of colistin and rifampin. But I myself don't have experience, and what we have in literature is some reports for very specific strains. So this is a combination that you have to try in your laboratory, but it is not as common that you can use it as other combinations which keep susceptibility such as polymyxins. I think there's a question there.
Bom dia. Bom dia. Parabenizá-lo pela apresentação, mas a minha pergunta é que aqui no Brasil nós só dispomos da fosfomicina via oral para tratamento de infecção urinária. Na prática clínica, às vezes nós usamos para alguns brasileiros para tratar algumas infecções fora urinária, como pele e partes moles, e eu pessoalmente já tive sucesso no tratamento. Qual a sua opinião de usar fosfomicina oral nessas situações?
Thank you very much for the question. I have no personal experience using fosfomycin orally for treating bone and joint infection. I think the PK profile of oral presentation of fosfomycin is not very good. You won't have very high levels in the blood, so you cannot expect very high levels in the bone and joints. It is very good for urinary infections, maybe for some cases of prostatitis, no, because you can get some concentration there. But I wouldn't use it myself. I think it's easy to develop resistance and to finally lose the treatment. It is true that intravenous fosfomycin is tricky. You are giving the patient very high loads of sodium, so you can have edemas, you can have heart failure, you can have ascites. In the case of cirrhosis, you have to monitor closely. And what is important is that we don't know the precise dose of fosfomycin, the sodium in the patient. We are using for gram-positives 2 grams every 6 hours, but gram-negatives probably need more. So it's tricky. I think we still need more experience. But I personally wouldn't use oral presentations of fosfomycin for serious infections in the bone and joint.
Jaime, eu gostaria de te fazer uma pergunta. Em infecções pós-operatórias precoces de joelho, artroplastia de joelho ou quadril, alguns dados mostram que o tratamento com retenção do implante para infecção enterocócica, por exemplo, tem resultados muito ruins. E, inclusive, com a possibilidade de precedendo o debridamento, a identificação do patógeno por uma artrocentese e, no caso de infecção enterocócica, indicar a revisão. Eu gostaria de saber se você acredita que em infecções por gram-negativos resistentes à ciprofloxacina existiria também essa possibilidade de mudança de recomendação cirúrgica para infecção precoce.
So if I understood correctly, if I have an infection by a gram-negative, a multi-drug-resistant gram-negative bacilli before, and I know this before the surgery is going to be performed because I have a joint aspirate, if I would recommend debridement and implant retention.
Or revision.
Or you mean removal? Guidelines say to remove. Guidelines are quite straight away, and they would say to remove. And the paper by Zimmerli, 2004, which is a referral paper, would say to remove the prosthesis. You don't have chances to cure the infection. So probably I would recommend to remove. But this is tricky, and this is not easy, because in many instances, what you have is an old patient with a revision prosthesis. He will not have the possibility of an exchange because he doesn't have bone stock, and the prosthesis is not loosened, it's well fixed. So for removing the prosthesis, you will have to perform a longitudinal osteotomy, which is a very aggressive surgery, and the patient is going to bleed, and maybe if he's got fever, this is going to kill him, no? So some people would argue in favor of, okay, the odds of curing this patient are very low, but you can still try, and if you fail, you will be always in time of removing the prosthesis. Some other people will say, yeah, but the functional outcome of patients who go to DIRE and they go to prosthesis removal is not the same as patients that go directly to prosthesis removal. So it's kind of tricky, and we don't have that many studies assessing the functional outcome of patients. I have reviewed this, and I think we can conclude that there is no evidence suggesting that if you try DIRE and you fail, the odds of curing the infection will be lower. So if it is an old patient, this is his last prosthesis, the surgery of removing the prosthesis is very, very complicated, maybe I would try the retention.
Nós temos para mais uma pergunta. Vamos para a última pergunta aqui do aplicativo.
Qual sua experiência com o tratamento de infecções e artroplastias por Acinetobacter com tigeciclina e rifampicina?
Very low. I've been seeing patients with prosthetic infection for the last 10 years. There are around 40 infections per year, so let's say I've seen 400 patients with prosthetic infection, and I can recall maybe 1 or 2 with Acinetobacter baumannii. This is not a problem at the moment in my hospital, so I don't get that patients. And I remember one, but that was a susceptible bug because that came from the street, so it wasn't a nosocomially acquired Acinetobacter. I don't know. Acinetobacter is not a very aggressive bug. It's very resistant, but it is not very aggressive. So I could try colistin plus peralactam, sir.
Muito bem, eu acho que eu também faria a mesma coisa, faria a mesma recomendação.